I'd like to thank everybody for coming to our sixth listening session with our DDSN commissioners. We're here today at the Union County Disabilities Board, and we want to thank our host, Brady Evans. He's here, and we are just thrilled to be here, and we appreciate the hospitality. What we're going to do here is we're going to speak. The speakers here in the room, so you'll know in the room you'll have to come to sit here at this seat here, and we're doing it off of a laptop here. Gary's got a laptop, so everybody on the team's discussion will be able to hear and see everything. So whatever discussion goes on, you need to sit here for everybody to be able to hear you. So that said, we will begin with some opening comments and remarks from our host commissioner here in the 5th District, Gary Lamel.
All right. Good morning, everyone. As was just stated a second ago, my name is Gary Lamel. Rob, if you can mute yours, I think we might be getting some feedback. I want to make sure that everybody out there can hear my melodious tones. Okay. As I said, my name is Gary Lamel. I am the commissioner for the 5th District, 5th Congressional District on the DDSN Commission. Some of you may be familiar with me from that. I want to welcome everyone here today for this, the people both in the room and those of us, those folks who are joining us online, willingness to be here today to help us make some decisions about how we're going to be building DDSN going forward into the future. This past year has been extraordinarily difficult. It has confronted us with challenges that are unprecedented in their nature across the state, and particularly for the persons that we serve here at DDSN. The people who have provided those services are true heroes. We want to express our thanks to those workers, those family members who have ensured that services have continued for our consumers, that they've continued to be delivered in a fashion that provides for those most vulnerable individuals to receive the services that they need in the midst of what is an unprecedented situation in our country. And so as we are going through today, what we are hoping is that those same individuals will come forward and let us know today their ideas, concrete ideas, for how we can improve our delivery system, where the gaps are, where the things are that are working well that need to be funded additionally. With regard to what we have received from the American Rescue Plan, and specifically what we're talking about here is there is a 10% federal match, FMAP, Federal Medical Assistance Percentage, that will be in place for DDSN from April of 2021 to March of 2022. This is additional money that was provided from the federal government coming to the state based upon our usage of home and community-based services for Medicaid. Essentially, this is extra money that they have provided to us for this year, and it's expected that it's going to be about $42 million extra for this period. I keep saying extra money. That money is to be used to add to, not to replace existing services. It's not to replace existing state funding. We can't go below, cut services, and replace it with that. But what we can use this money for is to expand services. Funds can be used to design and implement short-term activities to strengthen our home and community-based services in direct response to COVID public health situations. And we can also use it for longer-term strategies to try to expand the system and help out any programs or services that y'all feel are promising, have gotten off to a good start, but need additional funds to reach their full potential. And we're looking at a 3-year spend out of these funds. So that's the time frame that we're immediately looking at. And that's the parameters that we're working with. So what we want today is to get some feedback from you guys before we have to submit our plan to Health and Human Services, which is due very shortly. So that's why we're here today. If you want some more detailed analysis of the money, there are some handouts available that can be made available to you if you contact staff. But the emphasis right now is to be hearing from y'all, the stakeholders out there. And so I'm going to turn this over to Rob to get the speakers going, and we'll start having that feedback at this time.
Thank you, Gary. The first person we're gonna hear from is our host, Grady Evans.
We can make sure that mic is on.
Yep. Good.
Good morning. Just want to welcome everyone to Union County. The Union County DSN Board was established in 1986, and we provide supports to about 250 people. We're thrilled to have the commission here with us this morning, and all of our guests, and look forward to a beneficial exchange of ideas, coming up with a great plan. Thank you for attending this morning.
Thank you, Grady. And thank you for the hospitality. Next, we would like to hear from the Executive Director of Max Abilities, Michelle Schaefer.
Good morning, everybody. I'm just glad I got over all the cords without tripping to get to the microphone. Just a couple of thoughts from our agency and from families that we have spoken with as far as beneficial ways that we think that funding can be used. And the first is capacity building, looking at infrastructures, looking at ways that we can increase staff training, finding staff that can better address specialized needs than we may have now. Looking at approaching needs in a different way, looking at possibly residential facilities that might focus on specific needs that right now we don't seem to have, or for folks who don't fit into the conventional models of residential that we have. Looking at developing residential facilities that aren't residential facilities at all, using our waivers in a different way to help support families in or support individuals in an apartment that they might choose, and using technology and other in-home supports to give them what they need, but not to, they may not need that entire residential experience the way someone else might. It would be a way for us to take folks out of existing residential programs, support them in a way that is more beneficial to them, freeing up existing residential slots for folks that are on the waiting list that can't seem to get into a program and would cut down on some of the waiting list issues we have. We need to look at infrastructure needs as far as final rule. The purchasing of vehicles needs to be different. The way we approach buildings needs to be different. How we structure days need to be different. And all of these needs take funding and manpower to execute, which right now seems to be a difficult exercise. We're looking in our county as into developing a community supports department where we focus on building supports for families in the community. We need more respite. We need more providers of PCA services. We need expertise in these services, so families aren't experiencing a person coming in 1 or 2 or 3 days and then leaving to go to another family, and they're left without a support that they have funding for, but they can't find the person to provide the support. I think we're going to have to look at how we, at county levels, how we address that issue to provide that stability that families so desperately need. I mean, we have more folks living in the community receiving these types of supports than we have folks in residential programs. And definitely attention needs to be in that arena, more technology. We've got to find ways to recruit staff. We're going to have funds to pay staff so that we can be competitive in a very competitive job market. Things like hiring bonuses, these are all things that should be on the table so that we can get the best people to provide services to folks who desperately need it. And so we can provide the support for families who are willing and want to have their loved one in the community with them, but in a way to do it where they have some quality of life themselves. So in my mind, capacity building and infrastructure is one very large area that has many, many fingers that spread out. And then the other is a way to increase family supports and family resources to folks in the community who frankly are just not getting the level of support that they could certainly use on an ongoing basis. Thank you for your time.
Okay. Thank you, Michelle. Next, we will hear from Mary Poole. Mexico.
Yep, my name's Mary Poole, and I'm speaking as the parent of 5 children with Down syndrome, and I am advocating for those living at home with waiver slots and those waiting for waiver slots. Do want to say there are requirements that must be met with these funds, and Commissioner Lamel hit on them quite nicely. It must be used for activities beyond what is available under the state's Medicaid program as of April 2021. So he hit that nail right on the head. States may use the funds to meet home and community-based service needs created by COVID and activities to build capacity, which is what we all know is needed at the moment. We need to look at expanding covered services to reduce the risk of institutionalization. We need to raise worker compensation. That's direct worker compensation. There's multiple ways to do that. It's not just an hourly wage, as like Michelle has spoken about, is sign-on bonuses, longevity bonuses, things to keep people in the field. As they learn more, they tend to stay longer. So the more tools you put in someone's toolbox, the longer they'll stay and become, make this a career versus a job, which is extremely important. We need to actively recruit these workers, direct support workers, and a marketing campaign, a statewide active marketing campaign can be paid for out of these funds. Additional training for staff. I mean, we're getting folks that are coming into care. And again, for families, we need to, when we talk about training for caregivers, we need to realize that the largest residential provider the state has are families who are home with their family members. And so training them as somebody grows from a child to an adult, how do you handle those changes? How do you deal with behaviors? How do you do all these things? Folks don't intuitively know that. They need to learn it. So having a package of training for families is extremely important. And it's a void in the state. I applaud Maxability for their training they have on behaviors, and they need to do one on potty training. And there's a lot of things that that families just don't intuitively know, and that having that training would be great help. We need better case management training because life planning is extremely important so that the state of South Carolina can better plan for the future. If we don't have a good life plan, then we don't know what the future needs are for the folks that are around us. And getting case managers to understand that open-ended questions and building relationships is extremely important to do. It shouldn't be family driven. There should be both. There should be a partnership. So better training for them. We need to streamline the eligibility process. That's always been a burden on everybody. We need to reduce or eliminate the HCBS waiting list, including the HASKI waiting list. We need to cover family caregiver supports, additional supports. It's really hard to find anybody. So when we talk about building capacity, you can't just talk about building capacity for DSPs in a residential setting, a traditional residential setting. You need to talk about building capacity for the system, because the more you can keep folks living at home with supports, the less force it is on the system itself. And again, the biggest provider of residential services are the folks that are living at home. So we need to actively do those kind of recruiting, not just for DSPs in a residential setting, but PCAs, respite sitters. And we need to somehow incentivize traditional services to look beyond traditional services. In other words, if a board is looking at how do I increase revenue stream, which they need to because everybody needs to survive, they should be looking at PCA, respite. They should be looking at those ancillary services as part of their package of services and helping them market that and helping them get out there. So additional funding for an RN, which you need for PCA services. You need to develop residential supports without walls. Michelle alluded to that. Technology is a big part of that. So if you're talking about additional service needs, funding some sort of technology to be able to keep people in their homes longer without traditional residential services and relying on the waiver services for PCA and the check-in and some sort of training program, which I think is in the new waiver package. So I think that that would be a wonderful way to go. And we need to be looking at funding the person versus the location. Traditional DDSN funds location. It needs to fund the person. States must maintain current funding levels, so DDSN has to educate the legislators with regards to budget cuts to say that we can't have the budget cut because then we would lose this FMAP match. So it's kind of a, an incentive to keep you guys where you are. And you really need to be looking at, if you're not aware, there's an HCBS Access Act 2021 that's working its way through Congress right now that would put all these waiver services on state plan Medicaid. So the lower you can get that waiting list, the less of an impact that act would actually have when it becomes fruition. Given the current political climate in Washington, this probably has the best chance to pass that it would probably have at any given time. So thank you very much for listening.
Thank you, Mary.
And Rob, not to interrupt real quick, I'm gonna turn my camera off because I think we're having some stutters. And I'm hoping if I turn my camera off, it'll reduce the bandwidth. But I just want everybody to know I'm not going anywhere. I'm still sitting here. I'm just turning the camera off.
Okay. All right. Okay, next, we would like to hear from one of our parents from Witten Center, representing the Witten Center Parents Association, Linda Lee.
I'm happy to be here with y'all today. I know this meeting is about community service, HASKI waivers, but I'm kind of from the other side of the tracks. My daughter's been served at Witten Center for about 35, 36 years. And there is a place for centers like Witten. I think our state has done an awesome job of moving people out of the centers if they're able to move out. And Olmsted does not say there is not a place for such places for like Witten. There's always going to be a significant, small, but significant group of people who need those services. My daughter most probably would not be here today if she had not been at Witten. In February, she had a health incident, and thank goodness the nursing at Witten and the connections with the hospital there in Lawrence got her quick care that from where we live and trying to get into a doctor in a hospital, they were pretty blunt that she probably wouldn't have made it through it. So you have to look at all aspects. But for today, I just ask y'all with your community supports, and this is money coming in federally that does need to be used for specific. Mary, y'all made some great points. I like what you said. Don't make it look good on paper, is what I say. Make sure it's something that is useful, that don't tell somebody they're going to get 50 hours of service at home and you can't find a person to put in there, because that is what hurts. We're feeling the pinch in the regional centers and in the community because people aren't working right now. Hopefully that's going to change, but we've got to change their mindset. We have got to make it look appealing. We've got to train them properly. And we've got to encourage the people who they're going to be working with to accept them like family. Don't push them away. I do think sign-on bonuses is good, but I loved what you said about longevity, people who stay. We need to reward those that hung in there with us through COVID. Because if we don't do that, they're feeling like, well, darn, I just worked myself to death and all I got was somebody else is going to finally come in and they're getting a bonus. We need to make sure that these people that hung with us are rewarded, are thanked, and yes, rewarded. And that is everywhere. This money may help in the community, but the state needs to pick up for the centers or wherever else, because our direct care workers are our direct care workers, and I don't care whether they work in somebody's house, in a community setting, or in a regional center. All of our individuals that have disabilities are important, and we don't separate them, not in this state. We work with all of them. And that is my disappointment with this, is that all disabled individuals should receive the same caring and the same support. Case management. I believe that we need to be very careful. We need to plan for increased case management. We need to work on that. We need to make sure that they have the training and the support that they need. I was just reading something, and I know that the agency or whatever provider network of mentor is not always had a good name, but I read where the one in Oregon is leaving the state. They just leaving Oregon. 1,300 individuals are going to be without care. Only 25 of those were served in a residential setting. The rest is going to be hitting caseworkers and people who get services to and from the program. Our state DDSN handles a good majority of the care. Instead of looking for people to other providers and stuff, make sure we keep control of what we're doing and we support everybody. Because then you have a provider pull out. You don't want to be where you can't help take care of them. And they cited their reason for pulling out was they could not find qualified workers and couldn't afford to pay them. And so that brings on the next, educate our legislators. We will not compete in this market if we do not raise the salary. And y'all have done an awesome job of coming up with new requirements. Instead of basic direct support personnel, we're getting trained CNAs or physical therapy assistant type people who understand the equipment, understand the care. We're going to have to go that route and look at people who are qualified, who are proud of their job, We don't want minimum. We want people who are caring and proud and thrilled to take on and take care of somebody. But you won't get that without expectations and without paying them what they're worth. And then without continuing to treat them with respect. So I think that even though I do represent the regional centers, I think what I say goes across the board to the community, to everybody that's working with the disabled people in South Carolina. And I think that we should be proud in South Carolina. We have done better than a lot of states in caring for our individuals. But I want us to stay that way and stay at the forefront. You know, it's nice for South Carolina not to be at the bottom of the pack on some things. I was an educator for 35 years, so I know how the struggles have been. But I think we need to continue just working, even though we get this supplement in the community, make sure we keep across the board and educate our legislators that we're doing this for all of our disabled individuals. So thank you.
Thank you, Linda. I want to also let everybody who's online know that we can take comments in the chat. So if you have any comments to add, you can put them in the chat, and we will look at them. And so we're going to move on to our next speaker, Patricia Herron.
Thank you. I'm here in my capacity as a family member. We had a family member who was in a residential program formerly at Whitten and moved to a community ICF who choked to death in the facility, and we're a family member with another individual in a CTH2. I also represent the South Carolina Association of Advocates. I understand and I agree we need the regional centers, but we need for people to be safe there. And I have a concern that not only in the regional centers, but the residential services, we have not provided a safe environment. I got an anonymous email from someone at Coastal Center talking about a chokehold that happened in November. The person wasn't arrested till June. Same thing recently at Whitten. There was an incident that happened. It took months. So if this happens to us in our home, we expect the police to be there and we expect the person to be arrested immediately. So this isn't just limited to the regional centers. Our whole system of protecting people is broken. I have given you, I couldn't agree more with Ms. Poole about the need to support families. That's what the legislative intent is. And what I did on this chart, I took the money each year that DDSN asked for in-home supports, and then I took the end of year reports to see how much was actually spent on in-home supports. And as you can see, between 35 and 49% of the money that was intended to be used on in-home supports went somewhere else without legislative authority. So I have seen it in my practice. I work with people who live at home. One of the reasons I can't get people to work for them, even when they have the hours, is that $1 an hour raise that the legislature authorized and gave money for, as Ms. Poole says, most of the people live at home. Between 70% and 87%, according to DDSN's own accountability, it's 87% of the eligible people live at home, and 70 some odd percent of the people who are actually receiving services live at home. But if you look at the amount that's actually spent on home supports compared to the total DDSN budget, it's a small fraction. So one of the problems has been that the caps that were imposed in 2010, even though there's a case that says you can't impose caps if a person's at risk of institutionalization, caps are still being imposed, and only those people who can afford to go through an appeal with DDSN and then HHS are getting more than that number. When you have a person who's in a residential setting, whether it's an ICF or a group home, and they need 15-minute accountability, they're not going to be able to move home with 28 hours a week. So we need to use this money. We need to totally remove those caps. We need to restore some of the services that were improperly removed in 2010 when we were told there's a budget reduction. We gotta do away with PT and OT. Those are duplicative. Well, what happens is that our people, just maintaining the same level is progress. And under the state plan for PT, OT, and speech, you have to be showing progress. So those PT, OT, and speech, those services need to be brought back into the waiver so that people get them on an ongoing basis. I'm watching people now with contorted limbs. We're seeing, you don't see the effect immediately, but you do see it. The direct billing issue and the doing away with the bans, that's simply a federal law. You have to allow providers to bill directly. That's what the federal law says. That's what the legislature has said in provisos year after year. But yet here we are getting ready to submit a waiver amendment that nobody's seen, and we're still not allowing direct billing for residential. That has to stop because it's a violation of the law. Bringing the bans back into DDSN, that's not direct billing. We need to comply with the federal law on direct billing. Case management, the rates paid to case management are grossly inefficient. They're not being paid for the travel time. They're not being paid for the paperwork they need to do. That is not a federal prohibition. That's a South Carolina decision to limit what case managers can pay for. We have seen case managers dropping out across the state. This is going to really affect the people in the residential areas. So we need to, the other area where we need to increase rates is behavior supports. They're still getting the same rate that they got in 2009. At one time, it even went lower. So you cannot get, I called all 40 providers of behavior support providers, and there were about 2 or 3 that would even consider going into the home. So practically the only way you can get behavior support services is residential. And then why are we surprised when mom can't handle the kid with autism anymore? Why are we surprised that he's going into an ICF or he's going into a residential setting? Because we didn't fix it when we could by providing behavior supports. We have gone after some of the behavior support providers who tried to advocate, and we're not paying rates that make it feasible for them to go into the homes. I mentioned before that $1 an hour increase was never passed on to the people that work at home. People that are providing PCA services that I'm seeing are getting between $9 and $11 an hour. Unless you go with Charles Lee Center for respite, I'm seeing people being paid less than $8 an hour for respite. And then we wonder why they can't find respite sitters. Well, they can't find respite caregivers because they're making practically minimum wage. When we went to the legislature, when DDSN went to the legislature and told the legislature, we need $1 an hour increase so we can get direct caregivers up to $13 an hour, DDSN didn't tell them we need the $1 an hour increase just for the people in residential settings. The intent was to provide that to everyone, and there is no way you're going to compete when you're being paid $9 an hour at home and $13 an hour with benefits if you work in a residential setting. This is an opportunity to transform our system. There is money to make Olmsted a reality. and give everyone who wants to keep their family member, everyone in residential, everyone in ICFs, they should be given the opportunity, and the family should be told, you can quit your job and you can be paid for taking care of your loved one. I'm not saying close residential. I'm saying give people that choice. And that's not happening now. The list that was sent around people in ICFs who want to get out, that list, I think half the people were under age 30. And many of those people didn't even have behavioral issues. So why are they there, and do their families know that this is an alternative to bring them home? One of my other huge issues is that the boards and the providers are totally ignoring the Adult Health Care Consent Act, and they're getting consent from somebody who does not have priority on the list. And families have no idea what's going on with their family member in the facility. I've had families whose loved ones were raped, were beaten, repeatedly bitten, taken to the ER with human bites, and the family members have no idea. We've got a therapy system that was purchased without authorization from the commission, but we got a therapy system that would allow parents to log on to therapy and see what the case notes are for that day. I believe it would do the same in regional centers. Parents should be able to log on and see, did my child get taken to the doctor today? What was the result? Did my child not sleep last night? Are there increases in medications? Some of this money should be used to buy that therapy link that allows families to see what is really going on. We need to recognize DDSN currently has a policy that if a consumer is sexually assaulted, you have to have that consumer's permission to tell the family. Well, if you've got a consumer with an IQ of 36 and you've got the perpetrator saying, you don't want your mom to know, do you? That person isn't going to tell. That's just a flat out violation of the law. The Supreme Court has said that a person without capacity cannot consent to sex. We need to revise that policy. We need for families to know what's going on in these facilities. We've got the LAC report investigation coming out again. Why are we, I hope we're not redoing what we did before. Each time the LAC comes out, it says, oh, ain't it awful? DDSN got this much money for this purpose, but they used it for other things. I hope and I pray that this year the LAC is going to actually result in some changes in the system. Ms. Poole mentioned the new waiver package. The public needs to have access to that package before it is sent in. When the waiver package, a commissioner asked for copies of the waiver before it was sent in. We didn't know that DDSN changed from an individual waiver limit to an aggregate. I'm sorry, from an aggregate to an individual limit. There were changes made in that document that no one had an idea what was going on. So the proposed waiver needs to be published, and we need to have an opportunity to look at it and to make comments before it goes into CMS. The cost report issue, I tried to speak about that over a year ago at the DDSN commission meeting. The lack of transparency should be alarming, not only to families, but to the general public that's paying for this money that's going somewhere else. I have deposed a consultant who said that once HHS pays the money to DDSN, it's not Medicaid money anymore. And the DDSN can use it any way they want to. I've had 2 former finance directors say that. So we need to get a handle on this. The public needs to know. And when whatever that recoupment is, I've heard numbers from 10 or 15 million to 48 million. When that recoupment comes, it needs to not come from service dollars. That's what's happened in the past. There have been recoupments in 2012, 2015, multi-million-dollar recoupments. And what's happened is, in order to keep the legislature from knowing about these recoupments, DDSN has taken service dollars, and most of those service dollars come from the money allocated to provide services at home. We need to focus on Olmsted. We need to give people who live at home the opportunity, the hours, and we need to give the workers the pay that they're intended to have. One last thing, the nursing issue. I've heard Mr. Malley say, we've got a crisis in the regional centers. We've got to give bonuses to nurses so that we can keep them. Well, if you look at the Mercer report, DDSN is paying like 1/3 to 1/2 the rate for nursing that is the market rate. So people can't find nurses, and some of these people who are coming out of the regional centers who could be served at home, they need the nursing services. There needs to be a reasonable standardized method for determining that need, and the nurses that work in the homes should not be paid less than the nurses that are working in the centers. Thank you.
Okay, thank you, Ms. Harrison. We do not have any comments in the chat, so that is the end of our speaking portion. So I would turn to Commissioner Lamel for just sum it up and closing remarks.
Thank you, Rob. And thank you, everyone. And thank you, everyone who participated today. This sort of feedback is critical to us. Rob, again, if you can make sure you're muted. Thank you. Appreciate it. Sorry for anybody out there that you were getting reverb. Technical prowess is not necessarily what I'm known for. But again, that aside, just want to thank everyone for participating today, for being here today to speak on behalf of the consumers, on behalf of the providers, on behalf of the entire network that we have here at DDSN. The commission is holding these meetings all across the state. I believe there's one left in Commissioner Rollinson's district still coming up. And again, you're welcome to participate and watch that. Once we have collated all of this feedback, all of this input, we will be making our recommendations to DHHS with regard to what our plan is. If you do have any further comments or ideas, those of you who are listening virtually, please feel free to email them to me directly. My email is Gary, Gary .Lemel, LEMEL at ddsn.sc.gov. They set up those emails for us directly at DDSN, which is fabulous. So for those of you who may have an older email address, please understand that that one is no longer active, that I'm just using that. But if you want to email those suggestions, or if anyone here wants to email me the text of their comments, please feel free to do so, and I will make sure that that is passed on. I believe that since we have no additional speakers lined up at this point in time, that would conclude this particular session on behalf of the commission. Thank you.
Thank you. And just one other reminder, we have one more session tomorrow at 3 p.m. in Florence. So you can find that information on the website. And we will go ahead and close this meeting. Thank you.